Good morning and welcome. This is Brian Robson, the Executive Clinical Director here at Healthcare Improvement Scotland, and welcome to the sixth in our exciting lineup of QI Connect WebEx sessions in 2015. This is the 16th since the series started last year. This series comes from a request from our national clinical leads here in Healthcare Improvement Scotland to connect frontline clinicians and others interested in quality improvement with international leaders in the field of improvement. They asked that we make the sessions short, accessible and recorded to allow access at a time that suited them. And to do that, we use the wonderful medium of WebEx. I'm going to hand over to Jennifer now to say a little bit about the WebEx. Good morning, Jennifer.
Thanks, Brian, and welcome to everyone to the session. So just a couple of housekeeping slides just to get us started. If you could please use the chat box that you can see on the right-hand side of the screen to communicate, and I'll talk you through this in just a moment. If you are having any technical difficulties, such as not being able to hear the presenter speak, or if you keep losing connection, please message the events manager using the chat function or dial *0 on your telephone keypad. So on the right-hand side of your screen, you should be able to see a list of everyone who has joined the call. If you wish to make a comment or join the conversation in the chat box, please select all participants from the drop-down menu, circled in red on the slide, type your message and then send. And I should emphasise it's really important to select all participants so that everyone on the call can actually see the chat. So, where are you actually joining us from? On the top toolbar on your screen, you'll be able to see a blue arrow. And if you can just click on that arrow, you'll be able to just click on the map just to show, and it just gives us a flavour of where everyone's dialing in from on the session. Welcome to everyone. Cool.
Great.
That's great. So I'm now just going to hand over to Brian, who's going to give you a bit more background about the QI Connect series.
Great. Thank you very much, Jennifer, and good to see everyone joining in from across Scotland and indeed from the middle of the Atlantic Ocean. So welcome to everyone from across the world, and welcome to our friends and colleagues in New Zealand and Singapore also. So as Jennifer says, we've got a wide connection through QI Connect, and we're now reaching more than 282 organisations across the world, in fact. When we started the organisation, the QI Connect series, we were connecting in largely within the United Kingdom. We're now reaching 44 countries. And we're absolutely delighted with that. There's obviously something of great interest in connecting up quality improvers across the world. And when we started the series, we had one slide showing the organisations who are linking in. We now have more than 6 slides, and we're delighted to have so many friends and colleagues linking in to hear our speakers and also to take part in the discussion. As Jennifer says, the chat function is really important through the call today. We always call out a special mention to our university colleagues, and we now have a number of these universities linked in, more than 23 universities. We're delighted to have their connection in and have the students and indeed faculty join the call. And a special mention today to 16 new organisations who have joined the QI Connect series for the first time. Ranging from UK colleagues through to Western Australia, New Zealand, Singapore, and Argowan Hospice. We'd like to call it Argowan Hospice here in Scotland. Thank you very much for joining the QI Connect series. And as Jennifer has highlighted, the QI Connect series is recorded so that many of our colleagues can review and listen to the calls again, either individually or as part of learning groups. In fact, this is an image from Coawatea, friends in Counties Manukau in New Zealand, watching one of the recordings as a group and having discussion on the content of the call. We're also delighted to be an approved resource for the International Society of Quality fellowship programme. Delighted that they find use for our resources. We're a small team here, along with Jennifer, Carmen and Ross Stewart. We run the series, and we're delighted to have professional development accreditation forms that we send out to people who join the call, or indeed listen afterwards. If you contact Carmen, she will give you a certificate of attendance. We're also delighted to have a strong connection in with the Scottish Patient Safety Fellowship Programme, and we're delighted today that our first questioner of our speaker is Eddie Docherty. Eddie is an SPSP Fellow and also now the Associate Nurse Director and Lead Nurse in Ayrshire Health and Social Care Partnership. We're delighted, and we'll hear more from Eddie later in the call. And please remember to tweet. Everyone is recognising the importance of and value that we get from the wider reach from Twitter, so please use hashtag HISQIConnect to widen our reach further still. So today's speaker, we have a wonderful speaker from the other side of the world with a background in farming and agriculture and a 7-year period in management in British home stores in London. It wasn't until the early 1990s that today's speaker, David Mates, entered healthcare management. With a father and an uncle who were New Zealand All Blacks, David humbly suggests that rugby talent has skipped a generation. David has led management teams in hospitals both in North Island and South Island in New Zealand, and in 2009 was appointed as Chief Executive of Canterbury and West Coast District Health Boards. With a $1.5 billion health and social care sector budget and being the largest employer in South Island in New Zealand. David has overseen the creation of what has been identified as one of the most integrated health and care systems in the world by the King's Fund. In 2011, David was awarded the highest standing award by the New Zealand Medical Association for exemplary leadership in the devastating earthquakes in Canterbury. In 2014, David was made a member of the New Zealand Order of Merit for services to health. So we're absolutely delighted to have David Mates on the call this morning. Good morning, David.
Good morning. Right, going to look at taking you through a wee bit of the journey that the Canterbury Health System has been on. And again, just emphasising that this is a journey, and as with every health system, we all start from many different starting points. Now, I'm just going to touch on a wee bit about where we've come from, some of the very deliberate challenges and changes and investments that we've made over time, some of the results, and some of the next part of the next stage of our journey towards integration. So, to start off with, in terms of, hopefully you'll see the graphic in front of you, and health is very much a journey, and I think it is one of those sort of things that if we ever get to the end, I'm not, we will have totally missed the point, I think. But first of all, who are we as a Canterbury Health System? We're one of 20 district health boards in New Zealand, and Canterbury is the second largest, both by geographical size and population. And just to put a wee bit of context in, as a district health board, the primary purpose and function is the planning and funding of all the health services, health and social services for its community. The Canterbury District Health Board covers a population of about 525,000, around about 1.4 billion of funding a year. We directly employ about 9,500 staff, and then there's another around about 9,000 people that work in the broader Canterbury Health System with either contracts that we either fully fund or partially fund, and that includes general practice, community pharmacies, the aged residential care sector, home-based care support, and a range of NGOs. And again, you'll get a sense through that is actually the importance of how we've bound hundreds of small organisations together to operate effectively as one health system. And Canterbury is also the main tertiary provider for the South Island and the lower part of the North Island. So where has our journey begun? Back in 2007, the Canterbury Health System was, like many systems in many parts of the world, very fragmented, disjointed. We had the professional silos and tribes sitting within the hospital part of the system. We had general practice that, again, were isolated, disconnected. The aged residential care sector was something out there that no one really understood. And the ability for people to throw hand grenades and insults and every other bit across walls was part of our background and part of the history of Canterbury. You're going to hear me over time start changing the language from the Canterbury District Health Board to the Canterbury Health System, and there's a very deliberate reason for that, which again I'll touch on as I go through this presentation. If we carried on doing what we were doing in 2007, we were going to need to build another hospital the same size as the main tertiary hospital in Christchurch by 2020. We were going to need another 20% more GPs if we carried on what we were doing in 2007, and we were going to need another 2,000 aged residential care beds by 2020. And even if we had the ability to afford all of that, the major challenge we were going to have was actually where would the workforce come from. And this was the beginning parts of starting to articulate and get a sense of a whole health system in Canterbury, that in fact we had to look at doing something different. So our beginnings is very much like many health systems, fragmented, disjointed, and a lot of warring parties. The beginning parts of where we started to shape the health system was the creation of a shared vision of the Canterbury, of what a system was. And the one thing that was really clear and evident right at the outset was that many people had worked in health for most of their professional lives, but had no real concept that they were part of the whole system. And people didn't have a context of actually the role of general practice, or hospitals, or NGOs, and indeed actually the purpose of a health system to help support people to stay well in their own homes. So the beginning part of shaping a vision that actually involved more than 2,000 people across the Canterbury Health System, including the public, was starting to describe what they meant by integration and what they meant by an integrated health system. And the one thing that became really evident early on is while we often use the same words have different meanings. And we can sometimes think we're talking about the same things, when in fact, while we might be using the same words, we're actually talking about things very, very different. The core part of the vision actually had the home at the centre of the health system. And it's not that long ago that actually in Canterbury, the main hospital providers would have been sitting in the middle of that. You'll notice that it actually started to describe and give purpose and meaning for where does everyone sit within a system, and its role and purpose, and what people's contribution were to the delivery of a healthy community. Some core attributes sitting under that was actually a system that was connected, and one that actually shared information, was seamless, and for me as an individual, a patient, a citizen living in Canterbury, that I wanted to make sure that no matter where I went, someone had my health record. It was also centred around people, and that actually people remain at the centre of health, and most importantly, a system that aimed not to waste their time. And this has become increasingly one of the core metrics of the Canterbury Health System, is wastage of time. So, having got a sense of clarity about where we were trying to get to, a sense of common purpose and vision, we also were at the point as we could not keep on doing exactly the same thing we were doing yesterday if we were going to transform the way that we were thinking about health. So one of the things I'm now going to touch on is how we've brought this to life and enabled the change and the transformation to effect and bring to life an integrated health system. Underpinning the vision are three very simple strategic goals. The first one being that if you're going to have a healthy and well health system, people need to be encouraged to take greater responsibility for their own health. And that's been an important part of guiding investments, the emphasis and the importance that we've put on people taking greater responsibility for their own health. The second strategic goal is for people to stay well in their own homes and communities, with the need to be purposely and deliberately shape and support the development of primary and community services. And that is the primary point of where most people access their health services. And the third part was actually the beginning part of reorientating what the purpose of a hospital or tertiary centre was about. And that was about supporting, if people needed to receive timely and appropriate complex care. But the purpose of the hospital was, again, to free up hospital-based specialist resources to be responsive to primary care, to enable people to be supported to stay well in their own home and environment. And what you'll get a sense of is actually there's a consistent mantra that we've ended up and continue to build. Actually, what is the purpose of a health system? It is important to help you to stay well in your own home. It also required us to start describing a new way of working based on trust. You can't wish a transformation or an integration system to come about. So dealing with hundreds of small businesses, and the hundreds of small businesses, we have 140 general practices that are all privately owned. We have 112 community pharmacies. We have up to 5,000 aged residential care beds and somewhere in the order of about 90 NGO providers, just to give you a wee bit of a sense. What we needed to do was look at how did we bring all of those into a sense of being part of a system, and that's where we stopped talking about the Canterbury District Health Board, but much more of the Canterbury Health System. And that was the inclusive part, the inclusive language of saying you are part of our system. So we talk about one health system, one budget, and indeed we're neither one health system nor one budget, but we've given meaning to that. We're in fact hundreds of small businesses that could quite rightly say we could operate independently, have brought into working and operating as one health system, and conscious of the fact that there is only one health budget. And every time we waste a dollar, it's money that's gone, or any time we have $1, we can only spend it once. It's also been about people, and the focus has been much more on moving away from providers to where is the right care, right place, right time, delivered by the right person. So we've become increasingly provider agnostic. Again, the focus on leadership, the District Health Board's role to buy the right thing for its population, and again the focus on enabling clinicians, regardless of where they're in the system, to be enabled to do the right thing in the right way. And the final part of that was actually taking a whole system approach. And core to that was actually using information to plan and deliver service improvements. And again, every decision we now make in Canterbury is based on what is best for the patient and what is best for the system. Sometimes those can be in conflict with each other, and that provides some tension. What may be right for an individual may not be right for a whole system. The other core element is actually health is not about hospitals, but it is about a resilient system. The slide you're looking at now just highlights a range of very deliberate strategies and programs that we have invested over a period of time. And you'll see an earthquake somewhere in the middle of that. What most people probably haven't understood is the reason why the Canterbury Health System was able to withstand a major set of earthquakes is that most of what we've been talking about we had in place and were working before they happened. And in fact, the earthquakes have slowed us up a wee bit of where we would otherwise have been. So just touching on some of the deliberate investments that we've made to bring to life the capability and capacity to enable an integrated journey. One of those has been our Accelerate program, which has been deliberately about cultivating talent and innovation. And in this one here, we've now had close to 1,000 doctors, nurses, allied health and managers taken out of the health system and immersed in a program that engages them in theory, chaos theory, lean thinking, takes them out of the health environment. So we partner with lots of different businesses, including the likes of Air New Zealand, environmental organisations, biotech, hotel industries, and we then bring them back into the health system to enable them to deliver on a major health program. The reason we take people outside of health is that it actually is starting to build a different language that it hasn't been constrained by all the baggage of health. And all of this involves joint doctors, nurses, allied health and managers. So you don't get a group of doctors together, you don't get a group of nurses or allied health or managers. It is deliberately constructed to be done that way. As part of that, to give life to enabling people to do the right thing, they also graduate with a permission card that is signed by me, and they're able to play that card to remove any barrier that gets in their way of delivering the project that actually they have agreed with us. And each of them have an executive sponsor to enable them to walk alongside them. We've also invested in the creation of the Canterbury Initiative, which is a sustainable innovation process that's based and focuses on people, process and technology. We have a couple of GPs and a couple of engineers that actually work across the primary and secondary care divide in terms of connecting and engaging and bringing to life with the relevant clinical groups the changes that we require across the health system. We've also invested very heavily in health pathways, or created health pathways, and the core driver behind that was in fact getting and finding a way to connect the primary and secondary care part of the system. And the journey of health pathways is a very deliberate construct that often starts at the beginning, and it's normally a simple 5-step process, but the first one is often having general practice and hospital-based specialists in the same room that have often been throwing insults at each other and after 20 years of writing scathing letters about each other, meeting for the first time. And an important part of this process is actually finding or starting the beginning parts of people being able to let go of their history, their baggage, and also then to start engaging of, so how am I going to be part of changing the health system? Today we've got 761 health pathways live. In January 2009, we had 8. There are agreed ways of working across the health system, developed by health professionals for health professionals, and that is now across the whole of the South Island and most of the North Island of New Zealand, and currently every state in Australia. The access to that in Canterbury is 1.3 million views per annum. They're systematically developed, reviewed and updated, and by connected multidisciplinary teams working asynchronously. And across multiple health systems. Today, we're actually across 27 health systems and impacting on the healthcare of around about 20 million people. And all of that has been created and developed into a confederated health system where those 27 health systems now are jointly sharing and co-creating new pathways. When Eastern Sydney Health updates or changes a pathway, it is visible to the other 26 health systems as part of the confederation, and they can either adopt or change or modify that sitting within the process. And we now have 27 systems that are continually updating, creating and energising the health pathways. Why the health pathways has been so important in our transformation journey is, one, improving from within by developing the skills of staff. The second one is supporting integrated care, and particularly the one system, one place for everyone to contribute. And one of the challenges and things that we've managed to bring to life in the Canterbury Health System is the process of engaging everyone, not just individual projects. The third part of health pathways is encouraging collective and distributed leadership, and it's an equal opportunity to contribute and be part of a pathway contact irrespective of role. The fourth one has been promoting organisational stability. The fifth one is supporting change over time. And the sixth is making changes sustainable. And again, everything we've been attempting to do is to really make sure that we are building a sustainable health system. One of the other enablers that we've done is the electronic request management system, where, again, is built by clinicians, where every request now in the Canterbury Health System is now made electronically. And just to give you a sense of what that is actually the system has been built based around general practice and requests to all parts of the health system in Canterbury, which includes private physios, OTs, private hospitals, right through to the public hospital system. It identifies the funder in terms of whether it's the District Health Board or ACC, or in fact if someone's got insurance, what are their pathways that sit there. What it does, it makes it all visible. And again, we encourage people that if they've got health insurance, here is the referral pathway that we will take you through. The other element is the flip side of health pathways is health information in terms of where do I go as a patient or a citizen to find the trusted information about my health system and my care. And on this site, if you've just been to your general practice or a hospital specialist, they will give you a wee card that actually says, go onto the site here and you have all the information connected and available. The other bits that we've also had to look at doing is how do we change the contracting environment to enable people to be freed up to do the right things. And so we developed an alliancing framework, which is based on a new way of making decisions. And in health, we're often very good at confusing who needs to be making decisions. So often health systems get paralysed, seeking permission from someone else to say, yes, it's okay to do. So what we've done is actually clarified, actually there are a number of things, as long as it's consistent with improving the outcome for a patient and it's consistent with the direction of travel, do it. There are other things in terms of you as a provider or a specialty group, we do need to sit down and have a conversation, but you'll decide how things are going to happen. There are other elements where we need to sit down as a District Health Board and have a conversation, but we will decide. And there are various times when the Minister or a Minister of Health or the Crown actually determine that this is a priority for the government. So that developed into alliancing contracting, which is underpinned by a high trust, low bureaucracy, one health system, one budget, what's best for system and best for patient, and everyone wins and everyone loses. So Canterbury operates in a national health contracting environment, and it will be similar to what you have in Scotland in a range of different bits. But in Canterbury, when you sign into a national contract, you also sign into an alliance in Canterbury. What that means is you can throw your toys out of the cot today, but you have to be back at the table tomorrow and the next day and the day after until we've collectively found a solution to the problem at hand. What it does is it binds all of these hundreds of small organisations together that no one can actually stop or prevent the right thing from happening. And everyone has to be an active partner in that. And it's been a fundamental part that has changed and enabled a major behavioural change across lots of different professions and entities. It has now been rolled across the 5 South Island District Health Boards in the South Island, and that is actually binding 5 quite disparate District Health Boards into much more of a common way of working and operating. The transformation that sits between the hospital and specialist services and the primary and community services is where a lot of our transformation journey sits, and we've created what's called a Canterbury Clinical Network, and that is actually led by clinicians, and they help determine what are the core priorities within fixed funding envelopes. But what we do with that is actually we free up the ability for them to decide what is really important. How it works is confidence of the DHB through its planning and funding function that honours the process and implements the agreed outcomes, has confidence that it is the right thing to do and the funding will be found. It focuses people and entities and organisations on managing cost, delivering outcomes and not chasing revenue. And we had developed over time a lot of professionals that spent all their time writing little funding proposals to get a wee bit more money and then carry on doing exactly the same thing. So we've also enabled some new technology, and this is again supporting the integration journey. Health One, which basically is a secure system for sharing key patient information. We have now managed to connect all of general practice, hospitals, community pharmacies, Nurse Maud, which is one of our home-based support providers, and soon to be St John's, which is our ambulance provider. And at a touch of a button, you have all of the information and basically a central clinical record, regardless of where you are in the health system. What that means, it's also got a complex privacy framework matrix that sits underneath that, and that was an important part of getting many health professionals in silos to actually agree to look at sharing information. And when we started this process, there were times it would have been easier to stop and give up. We had general practice basically saying community pharmacists couldn't access health information because they were just glorified shopkeepers. And if they had information about a patient, they'd probably decide they needed a colonic wash and sell them the appropriate items. That was the extent of what the relationships were, of where we were coming from. One of the things that did emerge from this is that privacy was used as the Linus blanket to say, actually, I'm scared and I don't want to be involved in this. And one of the things that did emerge is actually general practice were actually really, really concerned about some of their records being visible to their hospital-based colleagues on the basis that they'd be criticised in the way that they were keeping their records. We had to work through that, and we've now got a system where today we've actually got over 500,000 Cantabrians at a touch of a button can have their health practitioner has all the relevant information sitting in front of them. We have made this actually system agnostic. What happens is data gets pulled from multiple different systems and creates a virtual health record. The other big investment we've done is kind of the focus on data and using data to turn into information to plan, predict and improve what we're doing, and the focus on removing waste and variation. And we've done that through partnering with Lightfoot from the UK and using signals for noise, which has been really fundamental to, in fact, bringing live information right to the fingertips of clinicians. Also, in terms of kind of a whole range of different pathways with lots of different metrics, visibility of metrics at every step along the pathway. We've also had a number of key programs that we've invested in. The first one is the Acute Demand Management Program, which is actually a program that is provided through general practice and community-based providers, and it is focused on doing whatever it takes to keep people out of hospital. In the last year in Canterbury, we managed 30,000 people in a community setting where anywhere else in New Zealand they would have presented to ED and or been admitted to hospital. We've also invested in CREST, which is Community Rehabilitation Enablement and Support Teams, where we provide intensive rehab in individuals' homes. Initially, it started off with a focus on the elderly, post-discharge from hospital, but now it is able to be accessed through the Acute Demand Program through general practice. And that's, again, been an increasingly important part for our elderly community. And if we tried to take this out of our community now, we would have an uprising, because every elderly person knows someone that has been through that. This is all consumer goal-driven, and normally it's about a 6-week program, and if they haven't achieved their goals within that, then they go down a different pathway. The other one is actually medication management service, where we've engaged the community pharmacists in conjunction with general practice to actually review all the medication management, particularly on the elderly, of reviewing all the chemicals they're on, and the dramatic drop in pharmacy usage in the elderly has just been dramatic. The other one, in terms of falls prevention, we've taken a system-wide approach to falls, and today, in February 2012, when we started this program to today, we now know that we've had 1,076 people aged 75 years and older fewer that have presented to ED with a fall. We have done 386 fewer fractured neck or femur operations. On any given day at Christchurch Hospital, there are 30 fewer beds occupied with someone as a result of a fractured neck or femur. And at 180 days post-discharge for those that have actually had a fractured NOF, there are 86 fewer people that have not died than would have been projected. That is where we're increasingly moving to in terms of outcome-focused healthcare and how we can actually demonstrate and provide the evidence that that is occurring. So what I've touched on is a bit of where we've come from, a fragmented, disjointed health system, some of the enablers that we've very deliberately invested in to really help bring to life integration. But ultimately, at the end of the day, integration only makes sense if it actually has made a difference. So what does it all mean for people? Our population is ageing. In Canterbury, we have the oldest population in New Zealand, and those 65 years and older, we're slightly ahead of the New Zealand average, but in terms of physical numbers, we have the largest elders population in New Zealand. So in just 4 programs that we have focused on, we have made 1.5 million days of saving of people waiting for access to care and treatment. People get well to stay and self-manage in their own homes. So we have now managed to plateau our acute hospital care. In particular, elderly people are getting support to stay healthy and independent at home, so they don't need to go to ED, and this is the ED attendances for those aged 65 years and older, and remembering that these are the oldest part of our population and the most rapidly growing part of our population. The proportion of 65s attending ED continuing to drop or ending up in hospital, and if they do go to hospital, they don't stay as long. And so what you'll see in front of you is the number of beds occupied by people 75 years and older for more than 14 days. So this includes some of the complex rehab component. And where you see the dramatic change is where we started bringing in a revised frail elderly pathway and focus within the Canterbury Health System. And also they're less likely to come back in terms of being readmitted the way they're being discharged. They can stay in their own homes and communities instead of a rest home. And the proportion of people 65 years and older in age residential care is continuing to drop. And you may recall that at the beginning of this presentation, in 2007, if we continued where what we were doing then, we were going to require an extra 2,000 age residential care beds. Today, halfway to 2020, or a bit more than halfway, we have in fact 400 fewer people in age residential care beds. Instead of being in there for an average, I think, of about 76, 78 months, the average now is down to 21 months, and we expect that to continue to drop. And those that do go to age residential care end up staying less time. Ambulance crews access people with COPD and take them to the most appropriate care, not straight to ED. So we've had a 32% reduction in people being hospitalised with COPD last year, and they were either managed in their own home or at a GP practice. In other words, we're keeping people healthy instead of in an institution. The flip side of that is we're also not admitting people medically unwell into hospital, and what you'll see there is the top line is the age standardised acute medical admitting rate per 100,000 for New Zealand, and the blue line below is actually the rate that we're sitting at with Canterbury. We're 30% lower than the rest of the country, and if we admitted at the same rate as the Auckland District Health Boards, for instance, we would have admitted last year close to 23,000 additional people just medically acutely unwell. This is where you get the impacts of integrated care in terms of fundamentally changing the need for them to be in hospital. Because we have been able to manage that, we've freed up hospital capacity to increase the number of electives that we're providing. And Canterbury is the largest elective provider in New Zealand because of our elderly population. So we've enabled more people to get elective surgery than before. And what has been interesting on that is halfway to 2020, we've enabled a 43% increase in elective surgery for our population without a single increase in occupied bed days. And again, we're undertaking the most complex elective surgery, and again, without having to change or to increase the amount of bed capacity being used. And again, the core part of that is so we can get people back into their own home instead of in an institution. The core stakeholders for the elective services are actually general practice and the acute medical teams. So it's no longer the surgeons that are the main of elective surgery. The reason that the elective surgery is able to be done is because the acute medical patients and demand is being managed both in the community, but if you do get into hospital, it is a far lower rate than anywhere else in the country. The core element that we're needing to, and we've brought to life, is that actually we need the whole system to be working for the whole system to work. You cannot sort out a hospital without actually having general practice as an integral part of that. And general practice cannot operate in isolation without actually having the hospital part of the sector actively engaged in what it's doing. The next part of our journey is actually connecting to an outcomes framework, which no matter where you are in the Canterbury Health System, it is visible in terms of the metrics and what you are contributing to the goal of an integrated health system here in Canterbury. I'm going to flick through a couple of slides here, and this was set up to be done on a Prezi, so it won't quite work the way intended, but you'll get just a wee bit of a sense. Is at the centre of that is Canterbury people are well and healthy in their own homes, and if you come back to that central vision I was touching on before, a connected system centred around people that aims not to waste their time. And here the increased planned care rate and decreased acute care rate. We started off those being two separate set of metrics and drivers, and in fact you can't separate the two, they're so interrelated. And each and every one of those has a whole range of different metrics in terms of what are the core drivers, how do we know we're making a difference, and that being reflected through at every part of the health system. In terms of things like decreased avoidable mortality, our surgeons have actually had requested that we report everything 180 days post-discharge. The reason for that is there's an increasing conversation in terms of should we have done a surgery if someone is dead within 180 days, were there other options and choices? And this is the power of data and information that is live and real, that people can go and interrogate, and you can go right back to 2008 with all the information here, right through to what's happening today, trends over the next kind of weeks or months, and a whole heap of stuff that would have taken years to do previously. So the health system outcome framework is the next important part. So just very briefly again, some of the keys summing up the kind of the approach that we've taken. Two bits. One is a review done by the State Services Commission, looking at what are some of the unique characteristics that the Canterbury Health System has done to enable innovation. And the four things they identified is have leadership that's clear about what it's trying to achieve in terms of outcome and goals, but flexible about how to reach those goals. It encourages experimentation and bounded and informed risk-taking. A customer-focused and solicit ideas from and engage with diverse internal and external sources. And the fourth one is have capability, skills and experience in innovation disciplines and methods, supported by resources. And then the King's Fund, again, had identified a range of characteristics that they observed within the Canterbury Health System. One of the ones there was consistent leadership that embraces common goals and aligns activities throughout the organisation. Quality and system improvement is seen as core strategy. Significant investment in developing the skills and capacity to support performance improvement. Robust primary care at the centre of the system. engaging patients in their care and the design of care, promoting professional cultures that support teamwork, continuous improvement and patient engagement, more effective integration of care that promotes seamless care transitions, information as a platform for guiding improvement, and effective learning strategies and methods to test and scale up, and providing an enabling environment in terms of buffering the short-term factors that undermine success. So how do we continue to keep focused on the long-term drivers while we deal with the short-term side swipes and issues that always come up? Are we there yet? Today, we're ever there, we're probably in terminal decline. But this is something that David Aubrey from the Innovation Unit in the UK identified in terms of, seems that wherever I travel from Rio to Sydney, many people in health know the Canterbury story. I've worked with numerous wonderful public sector innovation programs around the world, and I still regard the Canterbury Transformation Program as one of the most inspiring, innovative, incredibly effective programs that I've seen. Again, the process we're taking is how do we make things better today and tomorrow? The day that we ever think we're there, we're in terminal decline. And the one real challenge that is really important is also that we do not believe our own bullshit. The reason for saying that is it's incredibly easy to become focused and internally focused. And one of the most important things and characteristics is that we've now got a health system that is curious about what is happening in every part of the world, curious about looking at how we can improve and do things better. We've taken a whole of system process where we've engaged a whole system in change, but we have a number of broken pieces in our health sector that we have to continue to come back and fix up. And today I can sit with kind of 1 minute thinking, wow, this is just brilliant what we're doing. And in the next breath I can have my head in my hands thinking, I can't believe that we have managed to do this so appallingly badly. I think we've just become a bit more comfortable at recognising the two sometimes sit hand in hand. And what's important is that we don't get focused or sidetracked by the things that are actually not working at the expense of the things that are. But we also need to be continuing coming back and looking at how we continue to improve. So that's a very quick wander through a broad journey that we're on and a journey that still has a long way to go.
David, thank you so much. That was fantastic. And the chat box was full of comments and questions, and we'll come to them just in a moment. But let's turn to Eddie. Eddie, it's your privilege, and thank you for doing this, for asking the first question of David. Over to you, Eddie.
Thank you very much, David. That was incredibly inspirational. I mean, absolutely incredible work. Can I ask, what would you say is the key lesson Scotland's journey could take and learn from Canterbury? What was the key thing for you?
I think if we look back on the journey that we've been on, and I'd love to say that actually we were really clear as to where the journey was going, but that would be a total lie. But if I look back on the importance of some of the key enablers, and probably there are three things that I'd probably sum up. One is the connection of a whole health system to start creating a shared sense of what a health system is about, and creating that sense of a shared vision, and involving the community, involving every part of the health and social sectors, to start the beginning process of describing what they mean by integration, and actually what would be the core characteristics of a truly integrated health system, and how would you know whether you've been successful or not. The second one is the acute demand program provided through general practice has been incredibly important in our transformation, and that has been upskilling and enabling general practice to organise and have access to CTs, MRIs, whatever diagnostic testing they need, and also the ability to organise home-based care support to ensure that actually patients are able to be cared and managed through different pathways as opposed to hospitals. And, you know, as was touched on earlier, we've managed 30,000 people in a community setting last year, and that is the culmination, I think, of, or the power of organised, connected general practice. And I don't mean organised and coordinated in the same, meaning they're all in the same place, but actually been enabled to do and make the right choices. And the third bit has actually been the process and engagement through health pathways to enable the conversations to start between general practice and the hospital part of the system to start agreeing how they're going to provide care for particular diseases, conditions, or whatever that might be. And those three things have probably been the most powerful elements that, reflecting back over the journey we've been on to date, that have really given life meaning and enabled parts of the system that were fragmented and disjointed to start trusting each other and to start treating each other as colleagues and professional colleagues, as opposed to disjointed warring parties.
Thank you. Sorry, Eddie.
So I was going to say that's incredibly powerful statements, and there's two or three things automatically I think we can definitely take back to our own integrated partnerships and start the discussions, particularly things like upskilling for diagnostics and linking together pathways, really, really powerful stuff.
Thanks very much for that, Eddie, and thanks, David. David, we've got a number of comments and certainly a lot of praise for the slides and for your discussion and your journey. Sandra McNaught, a midwife with the Maternity and Children's Improvement champion at NHS Greater Glasgow and Clyde, says that there's similar fragmentation here in Scotland and she wants a David's Den card. Sandra McNaught from also says that she's looking forward to visiting you in New Zealand if she gets an opportunity. Andy Pender, who's a senior nurse in emergency medicine in Wishaw General, is asking, how does the one system work financially? What's the bottom line financially on this?
So, I'll give a slightly complex answer. Just to, out of the 1.4 billion that we've got as a district health board, we have to balance that to zero, i.e. break even, and manage all the demand and connections within that. As a district health board, we fund general practice about 55% of their income. The rest of that comes from patient co-payments. The same with community pharmacy. The aged residential care, we fund the whole lot of that. The public hospital sector, we fund the whole lot of that. And the NGO sector, we fund most of their income and revenue. So the One Health System, One Budget is very much that actually all we have is 1.4 billion. Now, is that enough? We can often spend a lot of time arguing about the pros and cons and says, well, actually, if we had 2 billion, things would be a whole lot easier. The reality is, as a country, we can't afford that. And so the emphasis is saying, actually, we've got 1.4 billion. How best do we use that? Now, the emphasis is on the we. And that's where the alliance framework has been really important in terms of saying, we spend, for argument's sake, 140 million on the aged residential care sector. What are some of the key strategies and enablers that, if we in fact change the demand, that in fact we could change the expenditure, which would then enable us to free up investment to put into a range of other programs. So what we do have is an incredibly effective and dynamic planning and funding function. And they sit within every health alliance conversation, not there to determine or say no, but actually just to make sure that things are being guided along the strategic direction, but also on the basis of actually freeing up people to say, how would we best make a difference with our community?
Thanks very much for that, David. And I know that a number of the questioners are thinking, and participants today are thinking through how the various finances work here in Scotland to emulate what you're doing there in New Zealand. A question here from Jean Robson, who's the Director of Medical Education at NHS Dumfries and Galloways. She says, to achieve all of this, there must have been a big effort to generate engagement. It would be good to hear more about the work that you did to develop this engagement. Yeah, the engagement has been fundamental. There are 18,000 people that work in the Canterbury Health System, and again, when I talk about that, that's GPs, and again, I talk about our health system, not about actually their individual contractors. The engagement has been really important, and developing a vision or a sense of what a connected health system looks like
invariably starts with a small group of people. And the challenge is actually how do you have 18,000 people and increasingly a whole community having a sense of ownership to the direction of travel for the Canterbury Health System. So we've used quite a number of mediums. The first one was we started off with 80 thought leaders across the health system, not necessarily people in positions or roles, but people that had the ability to influence and some key community leaders. And we took them out for 3 weekends in a series of interactive workshops that actually involved many other industries. In terms of encouraging people to be thinking about systems of, and not in a health context, but actually just getting their head around systems. And out of that started becoming some of what they saw as the core characteristics of what they saw as integration. What we needed to do was find a vehicle to take that to engage 18,000 people. And what we did is we rented out a huge big warehouse. And we dressed it up as a whole interactive, almost like a theatre type framework. We came through, each of the 80 people originally invited 10 people that they hosted on a 2-hour journey through this warehouse. But actually you walk through a big tunnel into an area that started off with all these suitcases full of all the baggage that we carry around in health, right through to an interactive journey of health systems that you would learn from around the world, to home, an individual's home dressed up, of actually what might a different consultation look like in the future. A range of different journeys that people would go with chronic conditions, right through to a bed, a hospital operating table that you would push through a wall in terms of what we were doing to what the future held. A range of different bits. At the end of that 2 hours, that group of 10 people sat down and had a conversation for about half an hour of actually what they saw as the core elements of an integrated health system and what they were going to do to change the system. Each of those conversations were captured by a graphic artist. So each of those 10 people left with a picture of their conversation, which they went back into their workplace and hung up on a wall. We had 2,000 people that went through that experience, and there was not one person in the Canterbury Health System that had not seen the outcome of that in terms of the conversation on a wall that prompted the conversations of actually people starting to talk about what integration was. And so we deliberately built a social movement. And not one of this was advertised. We did it deliberately to engage and effectively engage 18,000 people so they owned and felt that they had created the vision of the Canterbury Health System. Today we have a different warehouse which we use for prototyping. We have thousands of community groups through. We've got a house built in this warehouse that actually enables people to, and out over the Canterbury Plains, that actually we've had literally 5,000-6,000 community people through describing what they see as the core elements of an integrated health system and engaging them in some of the dialogue and conversations that we have, right through to prototyping new health facilities, integrated family healthcare centres, new hospital facilities. We have patient simulations through this warehouse on a regular basis. And so we've built in the concept in the context of actually community and clinician co-design of everything we do. And now there is nothing we do that actually does not have the community and clinicians involved in co-design. So we built a social movement, and that is something that has been so fundamental and integral in terms of actually effectively engaging with everyone that works in health, but more importantly with the community. And we now have a community that is so defensive and protective of their health system.
Thank you very much for that, David. And I know from visiting with you myself last year and meeting with your clinical leaders, with Alan Pithy, with Dave Knight and Stephen Henderson, just how engaged the clinical community are in all that work. David, we've reached the top of the hour. We have a number of other questions that will follow up following on from this call. But thank you very much indeed for taking part today, and also a big thank you to Susan, who's supported you from your office in joining the call this morning. And just before we finish off today, folks, just to remind you that our next speaker is Maureen Bisignano. who's the President and Chief Executive of the Institute for Healthcare Improvement, a good friend of Scotland, well known to many of you. Maureen will be with us on the 30th of July, 4 to 5 p.m. UK time. And once again, David, just to thank you again for you joining the list of exciting speakers for our QI Connect series for 2015. These are all available on our website, and I look forward to joining you on the 30th of July. Thank you all very much.